Hi, good afternoon, everybody. My name is Dr. Atsu Sakekwa from Ministry of Health, Ghana Health Service, Ghana. I'm presenting on hepatitis B birth dose introduction plan in Ghana. Ghana, as you know, is a small country in West Africa, population of about 31 million last year, with expected births of 892,000. Women's health, at least there is one ANC visit by 97% of pregnant women and 73% deliver in health facilities. We take a look at the trend of BCG and OPVO and Penta-3 vaccination coverages. The coverage for BCG is quite high over the last 5 years, and that of OPVO is within 70%. Reflecting the difficulty of early administration of this vaccine to newborns. As a country, we have a quite high coverage of Penta-3 within 90%. In fact, the last coverage last year was 96.9%. Looking at the evidence of hepatitis B, using surface antigen prevalence. We had some studies, published data that looked at the prevalence in general population and estimated it at 12.3%. This was published by Ofori, Asenso, and Ajiman in 2016. Prevalence among pregnant women is really unknown. Luckily for us, there is an ongoing CDC-funded seroprevalence study to estimate prevalence of surface antigen hepatitis B among pregnant women. Children under 5, the prevalence is modeled, estimated to be 0.64%, I think largely due to the administration of the pentavalent vaccine, which has reduced chronic hepatitis B among children. The process for the hepatitis B birth dose introduction. In the country multi-year plan of 2015 to 2019, hepatitis B birth dose was described as a potential new vaccine for introduction. But then NITAG, which is the National Immunization Technical Advisory Group, required evidence of disease burden. So in 2020, the CDC is assisting Ghana along with the WHO to develop a protocol to estimate the prevalence of hepatitis B among pregnant women using HIV Sentinel survey samples of 2019. So far, necessary approvals have been gained, and we are waiting for the study to commence so that the results will be presented to NITAG for their evaluation. The program itself will help to disseminate the results widely to build support and expectation for the birth dose introduction. We believe this request will be submitted to Gavi to support the government of Ghana in this regard. On hepatitis B screening policy, screening and prevention policy, on the screen, you could see that in our new maternal and child health record, there's provision made for birth dose of hepatitis B. So there is a high expectation that hepatitis B would be introduced somewhere in the course of time. The policy on prevention of mother-to-child transmission of hepatitis B is incorporated in principle within our antenatal care reproductive health policies. And the screening of hepatitis B among pregnant women is ongoing, even though it is not systematic nor reported. There are multiple rapid test kits in use, and many of them is difficult to tell whether they are of their efficacy. Normally, we have a Food and Drugs Authority that is interested in approving these kits before they are used, but many people use them without such approvals. The program also is yet to develop a testing policy or algorithm that can guide testing of hepatitis on mass scale. Now, we also are yet to update treatment guidelines for infected pregnant women in line with current WHO recommendations, which were released last year. So the situation in Ghana now is, even though in principle we accept the policy for preventing of mother-to-child transmission, it is not yet on public offer. Those who are affected by hepatitis B in pregnancy actually depend on imported hepatitis B immune globulin and birth dose hepatitis B, which are available privately to protect their newborn. Some of the challenges or the potential challenges that we expect, the most important one now is how to get early and convincing data for NITAG decision. We also foresee implementation challenges, including orienting our midwives to accept birth dose vaccinator role within labor wards, because this also go with responsibilities, and you know not everybody likes additional responsibility. Documentation is an issue. How to get midwives in their respective locations to access the cold chain and have access to the vaccine to use within the 24-hour window is also an issue. And also the reporting requirements that come with administration of vaccines. We also look at the fact that some newborns are born outside health facilities. About 27% or so are likely to be born outside health facilities. And how to reach these people within 24 hours is a crucial issue. It requires early flow of information, availability of staff at the moment to vaccinate an affected child at home, and also availability of appropriate transport means to address, to reach the mother at the time that is required. We expect some of these will be challenges that will arise going forward. Some opportunities, let's say, encouraging situations on the ground that we believe can help us a lot is currently we are having research technical assistance from CDC and WHO for evidence generation. In fact, a second study on the risk of mother-to-child transmission of hepatitis B has just been submitted for ethical review. And we hope that once it is going through, it will be generating additional evidence in support of the first one on the prevalence of hepatitis B among pregnant women. Funding has been secured for both studies through CDC. As a country, there is a cold chain capacity in every district. Even though this might not be down to community level, we believe this can be accessible in times of need in most places. The midwives are also already used to situations of time-bound administration of vitamin A, maybe within 72 hours, antiretroviral prophylaxis to HIV-exposed newborns. And also we have a health system that is decentralized with nurses placed within communities, or what we call CHIP zones, community health planning and services zones. So we believe with these factors in place, it can help in the introduction of hepatitis B birth dose in the country. Thank you very much. Over to you, Henry. Thank you.